Hi, my name's Debbie Long, and I'm an Associate Professor in the School of Nursing at Queensland University of Technology in Brisbane, Australia. Today I'm going to be talking to you about PICU liberation and post-intensive care syndrome in paediatrics. And I'm going to put a new lens on this, so bear with me and I'll explain what that is. I'd like to thank the conference organisers for inviting me to talk today. So as I mentioned, I'm going to provide a new lens of looking at PICU liberation and long-term outcomes in paediatrics. And I'm going to ask us all to put on a bit more of a developmental paediatric hat, because we're going to be just briefly talking about the science of early childhood development and also trauma-informed care and how we can bring some of the values and the principles of those not particularly new, they've been around for a while, learnings into our current critical care environment and how that might help with PICU liberation and also monitoring long-term outcomes in children and providing follow-up. So if we go to this idea of science or neuroscience in early childhood and development, and we know that brains are built over time from the bottom up, and that the interactive influence of not only genes but also our experience and environments shape that developing brain. And the brain's capacity for change decreases with age, and certainly that window doesn't close at a certain age, but learning new things becomes more difficult over time. And that all the domains that we look at in terms of child development around cognitive, emotional, social capacities are inextricably intertwined. So when we're measuring outcomes with children, we often don't just see something in one domain, we often see something in several domains. And we know that toxic stress, and which now includes pediatric critical illness and chronic illness, damages the developing brain, and that can lead to lifelong problems in learning behaviour and physical and mental health. And I guess, so what are the implications of this neuroscience and the development of the human brain? What are the policy implications or practice implications for us? And we know that basic principles of neuroscience indicate that the early preventative intervention will be more effective and produce more favourable outcomes instead of remediating later in life. So often we'll talk about early rehabilitation and early intervention. And in relation to the different domains that we look at, that we need to take a balanced approach at how we best prepare children and best protect their brains across all of those domains. And almost not single-handedly, but most importantly, is the supportive relationships and positive learning experience. Whilst they begin at home, we can provide all of these things in our PICU care. And most importantly, that babies and infants and children or childhood brains require stable, caring and interactive relationships with parents in any way or any place. So again, reaffirming that these cares, stable and interactive and caring, can also happen within the PICU. And then we know from the comment around toxic stress that it's intervening as early as possible is critical to achieving the best outcomes. And we know that for those children who do experience toxic stress, that the specialised early interventions are needed to target the cause of stress and protect them from the consequences. So when we're talking about protecting them from the cause of stress, this is how we're going to relate it to PICU liberation. And then protecting them from the consequences, this is how we're going to apply those principles to PICU long-term outcomes and follow-up. So if there were 8 principles that we were to take away around the neuroscience of building and developing healthy brains in childhood, is that we know that adverse fetal and childhood experiences can lead to physical and chemical disruptions in the brain and can last a lifetime. And we know that they affect multiple organ systems and increase the risk not for only impairments in future learning capacity and behaviour, but also for later poor physical and mental health outcomes. So we have an opportunity here to really make a difference early in the piece. We know that development's a highly interactive process, and outcomes or life outcomes are not necessarily based on genes. And while they have potent influences on human development, that environmental factors have the ability to alter these outcomes. So again, within the PICU, we have an opportunity to modify some of our environment and the interventions that we provide to prevent adverse development and promote healthy development. We know that children benefit significantly from relationships with other responsive caregivers, and they need to be nurturing and reliably available adults. So if we know that children who are in sort of negligent relationships, that multiple caregivers can promote their social and emotional development. And it doesn't matter if that's not their primary caregiver. We know that other responsible adults can do that. We know that the great deal of brain architecture is actually shaped during the first 3 years. A lot of our children in PICU are under 2 years of age, but they also continue to develop well into adolescent and early childhood. So although the principle of earlier is better than later, and that generally applies, that as I mentioned, that window of opportunity for most domains of development remain open far beyond the 3 years of age. And we do remain capable of learning ways to work around earlier impacts well into our earlier years. I mentioned about neglect and negligence, and that seems to actually be at least as great a threat to health and development as physical abuse. And whilst we don't like to see those things in intensive care, we know that social determinants of health are significant contributors to child outcome, particularly in PICU. And I guess the biggest take-home message from this is that a sustained disruption of what neuroscientists and child development experts call this serve and return interactions. And that's about engaging and having a response. We know that in studies of human development that parents who have a neutral face and don't respond to their child's verbal and facial cues can be quite damaging. So it's really encouraging these serve and return interactions even within the ICU, and encouraging those within the family partnership, but also with clinicians. Young children who've been exposed to adversity don't necessarily develop stress-related disorders and grow up to have problems, but we know that there is a small risk, and so we need to provide reliable and nurturing relationships and support caregivers, and also flag at risk those children who are at risk within the ICU of adversity and also poor long-term outcomes. We know that adversity also includes critical illness and chronic illness, as I mentioned before, and we'll talk about that a little bit later. We also know that simply removing a child from a dangerous environment will not automatically reverse the negative impacts. And whilst it's no doubt important to try and do that, children who've been traumatized need to be in environments that restore their sense of safety, control, and predictability, and they typically require therapeutic supportive care to facilitate their recovery. So even though we try and remove some of those things, we still need to be mindful that we might need to support them through their recovery. And finally, resilience requires relationships, not rugged individualization. And everyone's ability and capacity to adapt and thrive despite adversity develops through the interaction of these supportive relationships. And so these are the sort of relationships that we want to be encouraging in our intensive care unit as well. The other thing that's really important to bring into this conversation around PICU liberation and long-term outcomes is this idea of trauma-informed care. And this is becoming a much more topical discussion in healthcare literature, and particularly pediatrics, and sort of eking into the intensive care world as well. And this is developed out of theories around addiction and mental health processes, but we can draw principles from this into our intensive care. And also we know with the significant number of people living with mental health conditions, they have experienced trauma in their lives, and that trauma may be a factor for people in distress. It may be lifelong, and it can not only impact the person, but their emotions and their relationships with others. And we're starting to see this in data coming out of the early prematurity and the low birth weights. We know that that can be considered in a NICU environment an adverse event or trauma, and we know that it does impact on their emotions and relationships with others. Similarly, we know from adult intensive care, the similar patterns evolving, and also children with congenital heart disease, those patterns evolving. We're not quite there yet with pediatrics, but pediatric intensive care, but we know some of those patterns are occurring. Now, as I mentioned, this idea of trauma or adversity originally came from this notion of an emotional wound or shock that causes substantial and sometimes lasting damage to psychological development. But now we're seeing that term becoming a lot more broader. And we know that, as I mentioned, critical illness and chronic illnesses can impact and possibly seen as an adverse event or trauma in a child's life. And we know that there are physical development issues with that, but particularly psychological, behavioural, social, emotional, and cognitive issues as well. If we look at the 4 R's of trauma-informed care, there's nothing really new here. And in fact, if I put the 4 R's of PICU care, the realise, recognise, respond, and resist re-traumatisation would fit really well with our idea of rapid recognition and resuscitation. So the way that we respond to these things is in entirely the same way as what we would respond to an acute crisis of airway, breathing, and circulation, except now we're applying more broader domains around emotional, cognitive, behavioural, etc. And certainly when we're looking at the key ingredients to trauma-informed care, there's nothing here in these 10 ingredients, again, that are different from what are some of the things that we're currently doing in ICU around implementing other models of care. So co-creating and co-designing things with parents, making sure that everyone understands. So training and education and awareness is really important, and leading by example, creating safe environments for the child, the parent, and the clinicians, and in that supporting staff wellness, and really building partnerships with parents and families, and also broader interdisciplinary colleagues will help us to start building this trauma-informed care that we can provide. And again, we'll touch on that a little bit more coming up. So getting on to this idea of the A to F bundle and PICU liberation and PICS-p, so that's post-intensive care syndrome in pediatrics. You know, it's becoming increasingly understood that post-intensive care syndrome in pediatrics is a widespread but possibly under-recognised syndrome, and in particular now with the COVID pandemic, it's really shone a spotlight onto the long-term effect of intensive care and critical illness in adults and children, and now we're starting to see long COVID and long COVID kids. And we know that there's this growing risk factor to help explain the development of post-intensive care syndrome, and some of these factors are not modifiable. And it's important to our understanding as where and when we can intervene to either prevent or minimize some of these risk factors. So you can see here in the red box some of the risk factors that will contribute, and this is not an extensive list, that will contribute to poorer outcomes, acute and long-term outcomes in pediatrics. And I guess the difference with this presentation as some of the other ones is that I'm not going to talk you through step-by-step PICU liberation and PICU long-term outcomes. There's been quite a few talks about that to date, but how we can apply these principles of neuroscience in developing and protecting brains and trauma-informed care into these concepts of PICU liberation and post ICU follow-up. So for those of you who are familiar, the Society of Critical Care Medicine has come up with these two concepts of liberation, or the A to F bundle, and thrive, or post-ICU care. And the liberation bundle consists of these 8 components, and certainly for thrive, with the SCCM, it consists of ICU clinics and peer support. So let's just sort of delve into those a little bit more. So with PICU liberation, we have applied it in our setting in some ways the same as the adults, but also a little bit differently. So I just want you to stop and take a moment to think about why we call it liberation. And some people think it's a very American term. Obviously, it's come out of America, but we want to liberate people from the PICU. We want to liberate or free people from sedations and procedures. And in my mind, this is not just another list of assessments and tasks that we should be doing, or another fad thing that will pass on in a few years. And when we talk through these steps in terms of neuroscience and building healthy brains, that maybe that might help people think of it from a slightly different perspective. Certainly from the adult data from ICU liberation and over 15,000 patients included and large multi-center cohort studies, they showed really a dose response with implementing each of these elements or domains of the liberation, and incrementally improving acute outcomes with ICU, so length of mechanical ventilation, reduction in delirium, increased early mobility. So applying this to the children and PICU liberation, there's not been a huge amount of data. So it's relied on a lot of us to extrapolate where we can. And this is where I've found that the neuroscience principles really help with that. And when you think about most of our children, as I mentioned, are under 5 and particularly under 2, this idea of brain architecture and developing that really should be protected. And in my mind, PICU liberation is around protecting the brain architecture. So if we, there are a lot of PICU studies that talk about particular elements of liberation, but if we look more broadly into the child development literature to see how some of the different elements of PICU liberation can be helped by neurosciences. And certainly we know that pain early in childhood or infancy will influence at a later date child temperament, self-regulation and attention. So it's really important for us to minimize pain where we can, but there becomes a fine balance. In order to minimize pain, we often assess pain and provide pain relief. And we know that there have been some studies that show that excessive doses of opiates can impact on child development and also neurobehavioral outcomes, and that's been in both NICU and PICU studies. And also more recently in the RESTORE study, there was a significant relationship between the doses of methadone and functional outcomes, and in fact a decline in functional outcomes. So it's important that we address pain and we treat it judiciously with not just pharmacological interventions, but non-pharmacological interventions is probably the important takeaway message there. The B space, and the B space is around spontaneous and awakening and breathing trials, and this is the element that's had the least amount of information translated into pediatrics. But we do know that a lighter sedation regime, and this is a systematic review out of adults, has better cognitive outcomes. And the whole B space is around a reduction in mechanical ventilation and that lighter sedation. And you'll see how these all link up to the other elements. Certainly in choice of sedatives, the evidence is that midazolam significantly contributes to the development of delirium, and more recently a paper that's now in press, midazolam is also a predictor of early child post-traumatic stress symptoms. Certainly, we know that nurse-driven protocols around analgesic sedation help to minimize the exposure to benzodiazepines and withdrawal symptoms, and certainly do not provide any additional harm in terms of long-term outcomes. In terms of delirium, we know now with pediatric studies, thanks to quite a bit of work happening in the United States, that there's some early evidence to show that delirium is associated to a cognitive decline at PICU discharge. There have been some other studies which have looked at executive functioning and not seen any different yet. So there's just some early information, but we also know that children who have experienced delirium during PICU also have a reduced quality of life after PICU as well. In terms of early mobility and rehabilitation, there is significant evidence from the child development literature around movement and play and how that improves social and cognitive development. We also know that providing early mobility within the PICU environment will decrease the incidence of delirium. In terms of F, we know that in the adult literature, the F component was around family presence, and that significantly reduced the incidence of delirium within adult ICUs. But also we need to look at family engagement in decision-making and cares, and we do know that that has helped parents in terms of providing support to the child, which then goes back to the serve and return concept. In our unit, we have added in some extra components, and so ours is G for good nutrition. Other adult units are now putting in good sleep, but we include the sleep component within the delirium, and we know that sleep is essential for building healthy brains. But also in terms of good nutrition, there's plenty of child development literature supporting adequate nutrition and healthy development. And particularly, there's even more information about malnutrition or inadequate nutrition and how that impacts on development. In terms of the PICU space, there's been some studies looking at withholding early parenteral nutrition within that first week, and also tight glycemic control, and having a reduction in poor neurobehavioral outcomes even out to 4 years post-PICU. So that one's quite interesting. And certainly we've introduced H as humanism, and there's been quite a lot of child development and psychology literature around the humanistic values and providing humanistic care. And really these all evolve around that serve and return principle, and engaging with people and looking at their rights and their dignity and treating them as individual human beings. And we know that we can promote that by several activities within the PICU, but definitely around family-centred rounds. One of the last components of liberation that we definitely use within our unit, which really draws in at this neuroscience of building and protecting brains, is a concept that we call baby liberation. And this is all around efforts to improve developmental outcomes and providing neuroprotective strategies and early neurodevelopmental support. And we're drawing a lot of this literature from the NICU data and centres that have used the FINE, or the Family and Infant Neurodevelopmental Education, or the NIDCAP training into those centres. So we have included this within our PICU liberation across all of the elements. So it's not run in isolation, but we encourage our bedside clinicians to bring in the concepts of FINE and NIDCAP to all of the elements from A through to H. And we have seen in systematic reviews that these developmental cares, or neurodevelopmentally appropriate cares, particularly in the much younger infant ages, do improve cognitive, mental, psychomotor, and language development. So if we just touch briefly, and I apologise, these slides are busy, But the research that's been done to date around long-term outcomes in, particularly in PICU. So since we've had the development of the PICS-p framework that was done by Joseph Manning and colleagues in 2018, we've seen a rise of discussions and certainly papers around pediatric long-term outcomes after ICU. We know that there's a significant impact to health-related quality of life. And a lot of these children do recover, and we see improvements, but there are a small percentage of children, perhaps up to 30%, who have persistent decline in health-related quality of life and also in their functional morbidity. So we're starting to see with the improving mortality rates that these new rates of new morbidity and mortality doubling even out to 3 years of age. So this is really important when we're looking at how long we should be following children up for, that it's not just within 1 and 3 months. We really should be almost covering off on significant transitions in their life, so preschool age, primary school age, high school age, and even transitioning out to adulthood. We know from a family perspective that our parents experience acute stress disorders and also PTSD and anxiety and depression. And we really need to consider our parents and siblings in a family partnership model. So when we are addressing and looking at the child, that we're addressing the whole family unit at the same time. In terms of cognitive outcomes, we are starting to see significantly worse IQs and attention and motor coordination in children in certain cohorts as well, particularly in our more severely ill cohorts. And often what we'll start to see is this relationship between treatment and illness severity. And it's sometimes very hard to disentangle those two, because often the more interventions and treatments you provide are as a result of their illness severity. At a very fundamental level, these children are discharged with significant fatigue and sleep issues and ongoing emotional health. One of the really great things to come out of the raising of awareness with PICS-p is that we're starting to see a need to develop a core outcome set so that we're all measuring the same thing, which will help us with benchmarking and collating all that data in the future. So there's been some significant work internationally with the group around scoping review and developing core outcome sets and core measurement sets. So let's just consider some points for follow-up. And we've talked about some of each of these things as I've gone along, but we can sort of break up our risk factors into child factors, parent and family and environmental factors, and illness and treatment factors, which put a child at a higher risk of poorer outcomes. Now, some of these things we cannot modify and some things we can. It's very difficult to modify child and parent family factors, but the things that we can focus on are the illness and some of the treatment factors. And this is where the liberation concept comes in, particularly around trying to minimize mechanical ventilation and the length of stay and the extent of invasive procedures that we provide. Certainly minimizing exposure to benzodiazepines and opiates and the development of delirium is really important. If we come back to this idea of trauma-informed care and how we might integrate that into long-term outcomes for PICU and providing follow-up, we really need to, from a primary prevention perspective, start looking at research and clinical programs around the early detection or prevention of life-threatening illnesses. So we're starting to see things around congenital heart disease and sepsis, but there's more to come. In terms of secondary prevention, again, this is where PICU liberation comes in, is minimizing pain and invasive interventions, minimizing the development of delirium, but also if delirium does develop, minimising the time that a child has delirium and the severity of that. Looking at ways that we can screen and intervene on child and parent distress, and we know that those two are related, and obviously drawing on our interdisciplinary team to provide psychological first aid for both children and parents and also for staff. And then in terms of tertiary prevention, I mentioned before around social determinants of health and other co-occurring adverse childhood events, and considering those in how we help children recover from life-threatening illness. A wonderful mentor of mine has always said that PICU represents overly disadvantaged children from overly disadvantaged families, from overly disadvantaged communities. And if we just keep sending them back into that cycle, will anything ever improve? So that's where we need to consider these social determinants and whether we can change any of those things. We need to build on our public and policy awareness around education for PICS-p, because increasing the awareness and the education will help us implement these follow-up services for children, and also the early interventions that we might need to provide in order to improve their recovery. Certainly around screening and intervening those adverse long-term outcomes is going to become a very important thing for us to consider and to do. So putting that all together now is how we can bring in different perspectives and lenses to the care that we currently provide, and how trauma-informed care and the neuroscience around developing healthy brains and protecting brains can inform how we view and see and implement the elements of PICU liberation, and also how that contributes to post-intensive care syndrome for children, and how we provide long-term follow-up. I really hope that that has provided a little bit of a different perspective on understanding the importance of these two concepts in PICU, and how we might be able to drive this forward in the future in terms of teaching and research and also clinical care. Some of the biggest resources that will really help you with in terms of trauma-informed care and neurosciences, the Harvard Child Development, which you can find online, is extremely helpful. The Society of Critical Care Medicine obviously provides significant resources, and also the Piccolo network is now, from a PICU-specific perspective, developing resources for both parents and for clinicians to use, particularly across Australia and New Zealand. Again, thank you for having me talk today, and I'm happy to take questions via Q&A or on the email. Thank you.